I want to pinpoint that endometriosis is a prevalent, chronic, debilitating disease. And I've been practicing gynecology for about 20 years. I've taken care of many, many patients with early and mid stages and late endometriosis. I firmly believe that diagnosing endometriosis when woman is 30 or 40s and trying to get pregnant, that is way too late. So we need to shift diagnosis to early diagnosis and focusing on adolescents who are suffering from this disease.
Welcome to HealthBeat, a medical news podcast series from MJH Life Sciences. Today we're going to be discussing new guidelines to managing and diagnosing endometriosis with Joshua Fitch from Contemporary OBGYN. We're also going to be hearing from some experts in the field, including Dr. Alla Vash-Margita from Yale School of Medicine. Let's dive in. Endometriosis has long been one of the most underdiagnosed and misunderstood conditions in women's health, despite being a leading cause of chronic pelvic pain and infertility. For many patients, the path to diagnosis can take years, often beginning in adolescence with symptoms that are dismissed or normalized, and ending only after invasive procedures confirm the disease. But now, the American College of Obstetricians and Gynecologists have released updated clinical guidelines aimed at changing that trajectory, with a focus on earlier recognition, more timely diagnosis, and improved access to care. The recommendations come at a moment of growing attention on the gaps in how endometriosis is identified and managed, particularly among younger patients. Today, we're taking a closer look at what these new guidelines mean for clinicians and how emerging tools, including potential non-invasive biomarkers, could help reshape the way this condition is diagnosed and treated. I'm joined now by my colleague, Joshua, who has been covering this topic for Contemporary OBGYN since the new year. Joshua, how are you doing today?
Hi, Kevin. Doing good. Thank you for having me.
Thank you so much for joining. I really do appreciate your time, Joshua. And obviously, we don't get to talk enough about wins and endometriosis, so we'll make a meal of it for sure in this conversation, I'm sure. Let's start at the baseline, at the highest level. What makes these new recommendations from FACOG different from what clinicians have been working with in endometriosis previously?
Yeah, so the biggest thing in the guideline is a push for earlier diagnosis by way of earlier recognition of symptoms and consideration of endometriosis earlier in age. There are a lot of endometriosis-like symptoms that, we're told can be kind of moved on from in the clinical setting as symptoms of something else rather than that suspected endometriosis at that earlier adolescent age. Dr. Stephen Fleischman, who is the president of FACOG, said when the guidance was released that the community's hopeful more clinicians will kind of just feel a comfort level to diagnose endometriosis and initiate treatment sooner if it allows. And you can imagine that will help patients access their clinical care faster, he said, allow for support throughout the process to come about naturally because it's in the front of mind and actively being pursued, in some cases, 10 years earlier than a diagnosis, in the 30s or even early 40s for some of these patients. And don't forget, this is a welcomed approach to be endorsed and pushed from one of the, if not the leading medical society in women's health, because there is an average of a 4 to 11 year after symptom onset to receive a diagnosis of this debilitating disease. Recent research, Contemporary OBGYN covered from France, which was published in the Journal of Women's Health, revealed that those diagnosed with it, in fact, had an average diagnostic delay of a decade or more.
Wow.
So, those numbers can vary 4 to 10 plus years, but there is evidence that some of these, on average, take 10 years to get diagnosed, which, of course, is a major red flag and a big push behind some of this, some of this coverage that has led to some of this coverage like we're talking now.
Absolutely. And I mean, that's not even to infer the fact that diagnosis does not mean immediate resolve. That's just the initiation of treatment itself when you've identified it. So again, just long overdue for patients, a streamlined approach to it, which we'll approach a little bit more in our conversation in a moment. I wanted to talk a little bit more historically with you about the diagnostic pathways that we are using to identify endometriosis. Laparoscopy is a very vital tool that is used in it. And I wanted to ask you why exactly that is. Why is it such a central part of confirming endometriosis, this invasive procedure?
Well, part of it is the gold standard. We know in medicine it can take a very long time to change overarching aspects, for clinical diagnosis, especially you can argue, especially when it's been in place for this long. What we hear is it folds into what we've kind of touched on, that there is a way to diagnose it despite it being invasive, but that is the gold standard. So what I've gathered in some of my conversations with the doctors and the KOLs is it becomes or needs to become kind of more of a mindset shift among the providers and the patients to a degree to see symptoms preemptively, more to recognize before disease progression, before those worsening of symptoms, to get the point for the patient that they feel they need that invasive surgery, because once that disease progresses, there's only so much to be done in those late stages, and at that point they're going to be having those conversations because the symptom pain is going to be bad. Some of the downstream quality of life impacts are going to be popping up, what be it a discussion about the endometriosis itself and the suspectedness of it, or even at a well-woman visit. So it's just a whole different echelon of approach from the patient when they're in that setting versus maybe a presumptive diagnosis, which we'll touch on in a little bit, where they're kind of in the process from the beginning and have a wherewithal and idea of what this undertaking might look like.
Of course, it's the truest resolve towards actual confirmation. So interesting to learn. Exactly how do we hope that the new recommendations will help to shorten that timeline, that extreme timeline we're seeing from symptom onset to diagnosis among the average endometriosis patient?
Yeah, that's the key of this whole thing. The guideline authors and ACOG noted that this, traditional reliance on surgical findings to diagnose endometriosis is, the key part for the diagnostic delay, oftentimes because it's invasive. Patients, while they may not have the medical knowledge, certainly know what that procedure looks like, and they know the pain associated and, those just several headaches, of course, you can say, that come with a surgery to begin with. The new guidelines highlight how to use earlier clinical findings, imaging, tests to provide presumptive diagnosis, is what they're calling it. Dr. Bliss Kane-Shiro, a named author of the guidance, said these presumptive diagnoses are based on patient history, which of course is something our providers take to heart. They take very seriously. They're very good at symptoms and physical exam findings. So these clinical diagnoses allow physicians to offer patients kind of medical treatment while the process is still continuing versus a cut and dry approach to determine diagnosis with imaging studies, etc. So the authors stated in the guidance, this allows the patient to feel better faster. They're looped in quicker. It's not as intense of a discussion in the beginning, and really help them connect with the resources and support sooner. And you can imagine that from the patient point of view, they may come in having to already have this difficult conversation with their provider who may suspect endometriosis, for example. This approach has to make the patient feel more involved, at least in the beginning. It's not an immediate conversation about surgery, and they can feel their stresses are being taken seriously and approached kind of in a new way where they are at the forefront and being heard.
The delay coming down to symptoms, including or especially really menstrual pain for patients, how much of this do we see as an issue of interpretation at the primary care or pediatric adolescent medicine level for patients?
Yeah, this is something that has been brought up to me a couple times. And again, I think it fits into this larger theme of a overarching shift in mindset, from an early standpoint with these patients, both in age and in awareness. I recently spoke with Dr. Alla Vash-Margita, who's an associate professor of obstetric gynecology and reproductive, as well as the division chief of pediatric and adolescent gynecology at the Yale School of Medicine. This is an interview that is on the Contemporary OBGYN website. She recently led, along with Dr. Hugh Taylor, a study that highlighted microRNAs as a potential earlier detection biomarker for endometriosis. We'll touch on that in a little bit, but in our discussion, Vash-Margita highlighted that there's been a normalization of menstrual pain or cramps, and that in medicine, that's the only type of pain that is normalized, she said.
And that's a gap. That's a problem. And I say we have to start educating our medical students, our residents, our fellows, pediatricians in the community, because it is not okay to have just painful periods. I've seen it, I've heard it. Pediatricians will say, oh, you have painful periods, take Motrin, go along your way. That's not okay. We need to listen to our patients. I tell my residents and students, if all fails, go back and talk to your patients. If you don't know the diagnosis, go back, talk to your patients. They will tell you, they will guide you, and trust your patient, trust your instincts as well.
She added kind of a keen listening aspect to the patients that is so important as this larger idea shift begins to take place and begins to refer to those presumptive diagnosis of endometriosis. And of course, that ladder to diagnosis in this fashion, I'm sure will take time to get down and get into the clinical setting. But again, it's really a mindset shift.
Turning back again a little bit to the methodology around endometriosis diagnosis, because it's an interesting conversation, like I was trying to highlight before, of laparoscopy being, as you described, the gold standard. A lot of conversation, of course, when we talk about improving diagnostics for really any space, not just endometriosis, is focused on timelier methodology and less invasive procedures, the most simplified, easiest win, fastest approach to identifying the issue. That said, you have talked to surgeons like Dr. Laura Liu, who made it very clear that imaging still misses smaller, complex disease in these cases. Are we dealing with two competing realities here? Is there a place where these can play a complementary role, or as you're describing, we're just sticking to the golden standard?
Yeah, it's interesting because I'm sure it's a little bit all-encompassing at this stage in the game. In a written Q&A with contemporary OBGYN, Dr. Liu said, though imaging has come a long way, surgical diagnosis is still needed first because of what the images can miss. For example, she said MRI can take up to 2 millimeters images, but endometriosis lesions can be less than that. So they can be missed in imaging approaches like that. So from what I've heard, it's very much a continued push, as there can be, for the technology that will help earlier diagnosis or get clinicians on the pathway to consider that diagnosis earlier. And if that brings up a conversation, even for the invasive surgery route at an earlier stage, there's potential there that that's still beneficial because it is earlier time to diagnosis, potentially by years. So the surgery is still very much going to be here. It's a continuing effort, I think, to bridge that gap, in these guidances, studies that are coming out, biomarkers. I think that's all part of the shift. But yeah, the laparoscopy for right now, from what I gather, by a feasibility and just reality standard, isn't going to be going anywhere.
As we're discussing with non-invasive diagnostic opportunities, you alluded to it before, potential biomarkers are also always a hotbed topic when we talk about refining diagnostics. That said, given everything we've been discussing, do our experts really see these replacing surgery in some kind of capacity as discovery is improved in this? Or is it more realistically going to help guide who needs the, invasive diagnostic approach in the first place?
Yeah, these are, in some cases, preclinical findings. So again, this is that early stage where it's exciting, movement is finally occurring. And I think that's the message of the overall theme for endometriosis. And you can even argue, on a larger scale, women's health overall. The biomarkers represent this push, right? But with preclinical findings and some of the discussion I talked with Dr. Vash-Margita about, they're just not there yet for implementation. They still have to go through, phase clinical trials, et cetera, to develop potentially, a routine test that can be developed, for these biomarkers that is, completely non-invasive.
So we analyzed over 800 microRNAs, but then we looked at specifically ones that were unique to adolescent population. And we realized that there are four microRNAs that were significantly highly elevated in patients with endometriosis. And there were 18 unique microRNAs that were significantly decreased in patients with endometriosis. So this gives us a pathway or signature microRNA profile that potentially can be used as a biomarker, as a non-invasive biomarker for diagnosis of the disease. We're super excited about these findings. We're hoping to move to clinical phase trials. And needless to say that even laparoscopy is a major surgery. It requires general anesthesia with possible side effects and some risks involved. In laparoscopy, we take every surgery seriously. So, an adolescent patient and her parents, for most parts, want to avoid surgery. So, if we as physicians, as a medical community, can offer a non-invasive test to, with certain precision, diagnose endometriosis, that'll be great. And I also want to emphasize that this will be just an adjunct to our same pathway, our clinical history taking, family history taking, physical examination, ultrasonographic findings, and then we'll have a test, a blood test to offer, which is easily done in the clinic setting.
Just imagine the benefit baseline for these patients and for the caretakers who have to, facilitate these surgeries, strain. There's so many avenues that would open up. But again, these are in the early stages. However, it cannot go or cannot be understated or overstated, I should say, how important these initial steps are because these are the first steps, and there is now a clear pathway, studies being rolled out, data being published, and really a tone I've gathered from people I've talked to in the community, the healthcare community, who deal with endometriosis and who have worked with these patients, that there is some momentum now, finally.
Yeah, at long last, it's been very, very long awaited, as we've described. So, I mean, again, to put a bow on this and to put into context for folks who may be less familiar in this specialty and this focus, this is a place and a patient population that, again, as I described at the top, not had a lot of wins. And we've seen this sort of historically in general in women's health and pharmaceutical advancement of, there's less viable options. There's fewer, treatment methodologies available, and therefore things like diagnostics and screening suffer because, not to say what's the point, but it's a little bit of a defeatist mindset at some of the turns, unfortunately. So at the end of the day, what is at stake for us clinically if endometriosis continues to be underdiagnosed or delayed like it has been? What's it causing to the physician workforce, the clinician workforce?
It's costing a lot. I mean, we live in a world today where we continually hear, and from my previous coverage on our sister publication, Contemporary Pediatrics, that general providers, in that case, pediatricians, are continually taking on more and more responsibility because subspecialty wait times are still at very high levels and very long wait times. Patients have access to information, whether that be the correct information or not. They're bringing questions into their general provider's offices, whether it be a routine physical or a well-woman exam with their OBGYN. So that, even from a baseline level, can put a strain on healthcare and, attentiveness to patients by default. When you bring in something like endometriosis and surgery, and the pain chronic that is, and the fact that this is can occur to women across a wide age range, there's so many potential hiccups that can come up. So the downside of this is continued wait times. Wait times we've seen in research have increased to diagnose endometriosis. And we touched earlier, we're already at an average of 4 to 11-year time span. So I don't think the space and the community can really afford for that to get much worse because the patients are going to continue to suffer through that. Additionally, removing or taking steps to remove the invasive aspect of this, just imagine the patient day to day in dealing with news of endometriosis, knowing that things are being taken care of, or the appropriate attention is being given to you because you brought up your symptoms to your doctor. I mean, the downstream impacts of this guidance, and I think the clinical awareness of diagnosing endometriosis early speaks for itself. And there's just so many downstream benefits. Cost is another thing that can really be impacted the further the diagnosis of endometriosis is prolonged, because worsening symptoms leads to worsening disease, different clinical stages of disease, and then you're talking about different avenues of care, the surgery itself potentially. So there's just so many negatives associated with this long diagnostic time for this debilitating disease. And it's really encouraging that ACOG has kind of put this guidance out. Again, I said earlier, they're a leading agency, and society in women's health. The meeting is coming up soon. That's May 1st through 3rd in Washington, D.C. And of course, the contemporary OBGYN team is going to be there covering the latest. And I have no doubt in my mind that endometriosis is going to be a prime topic for that meeting, because not only of these recent guidance, but because this topic is carrying momentum in the field.
It's as you so well put it there, it's helping reduce the perpetuation of the stigma around women's health-related pain and symptoms and sensations, as you've described. I think back to covering other specialties and topics before and learning, the significant amount of major adverse cardiovascular events for women that end in death because their symptoms may be misinterpreted as hysterics or an anxiety attack or something mental health related when they come into the emergency room, whereas it is widely understood and appreciated that it has an extreme effect on men, and that would hardly ever happen in such a circumstance like that with what they're presenting with. And to hear it before of like the only excusable pain in medicine, yeah, that's unfortunately just a concrete fact, right? This is very unprecedented. So anything that can help contribute towards denormalizing what these people have been going through, as you described, on average, a decade after it starts, is going to be, it's going to have cascading effects for years to come. So it may just be guidelines and recommendations. It may not be packaged with a fancy new biomarker panel or a new non-invasive, diagnostic tool. Those are all ambitions still, but it's the right step, right, Josh?
Absolutely, and very well said. And this is something that will take time. It's something, though, I want to stress that the community is really proud of, and from all aspects of this to kind of get to this point, as what I'm gathering is a hurdle of itself because of those stigmatized, claims we highlighted. The diagnostic time and the statistics speak for themselves in that regard. So to kind of overcome that hurdle and get some formidable guidance published in a trusted source, and amplified by brands like us who have these discussions with those who know about it, is really important. I think, is going to be key as developments continue to come. And, as we see kind of this thing get the spotlight it deserves, and really hopefully turns into some relief and earlier understanding for the patients that have to unfortunately go through this.
Excellent. Thank you so much for this, Joshua. I really appreciate your time. As you alluded to, a lot to look forward to on the coverage, including the team's live coverage of ACOG in DC in the beginning of May. I'm looking forward to that. Just really appreciate having you on the program to talk about this.
Oh, it's my pleasure, Kevin. Thank you for having me.
Absolutely. And that's going to be all that we cover on endometriosis today, but you can follow Joshua on LinkedIn. You can learn more about endometriosis at contemporaryobgyn.com and follow them at Facebook, LinkedIn, and on their YouTube channel. Check out the links below for resources and references that we made throughout the show, including Joshua's recent interview with Dr. Vash-Margita. For The Health Beat, I'm Kevin Kunzmann. Thanks for listening in.